Uh, yeah, unfortunately, we don't have that much time. Also, it was my fault. But if there are a few questions, we will try to collect them. Yeah. I don't know if there is a microphone that, yeah.
Good afternoon. Lieven Normans, Professor of Health Economics. So I like the session, of course. But I have a problem. I don't want to spoil the party, but when you talk about the economic dividends of the healthcare sector, it's only part of the situation. I make a comparison. Suppose that you pay 100,000 people to dig a big hole, and then you pay those same 100,000 people to fill the hole again. Then you created an economic dividend, you paid them, that you created income, you paid the suppliers because you need material to dig the hole and so on. But in the end, you did not create anything. You made a hole and then you filled it. And that is what we understand by that economic dividend. So you can only really talk about value if you talk about that health dividend. And I was a little bit disappointed to see much less figures there. I saw a lot of figures on the economic dividend, but not on the health dividend. And Bengt, you showed some nice regression analysis where you showed the link between life expectancy and economic growth. But I wonder there, so the first was a comment, but you can comment on my comment, of course. The second is a question. I wonder whether there are similar studies relating healthy life expectancy with economic growth, because I think that relationship would be much stronger than just the life expectancy.
I can take the last one, which was, I guess, the easiest one, while Professor Henke is really on the tough question here. Well, I think that Robert Barrow is correct that health has been introduced into growth models rather recently, and these are general economists. They are not really health economists. They are using the generally available statistics on health, which is basically life expectancy. I know that some people who are working in this field now are using other, like healthy life expectancy. They are using the daily calculation as health burdens and so on in this. So as I say, there are many definitions of health. I think it is particularly important in order to understand the relation between growth and health to really apply different measures and health. So I think we will see very much more of this in the future. I just make the remark that life expectancy is obviously the most, in a way, general available, but also simplest models. When we are going to get more refined measures of health, we will probably see even also more refined links between health and economic growth.
I think it's okay. Can you hear me? Thank you for your questions and about the comment you made on the calculations. I think that the economic footprint is something very severe and something that you can really calculate for different areas, for education, for defense, and it is done in different areas as well. And here we have tried to do it with the direct, the indirect, the induced, and the multiplier effects. And this is what we have shown so far. I mean, you are right that the health effect is what you are interested in, and I'm interested in as well. But on the other hand, there is the health economy, and they have a contribution to what we are discussing. The question is whether you look only at the institutions, the office-based physicians, and outpatient, inpatient care, and ask for the health benefit of their doing. This is okay, but here the economic dividend was in the foreground, and I think this is what I've shown you, a basis for economic decisions. When we discussed this in our ministry, for example, the other branches were all in the sudden on the agenda, and they are sometimes supported by certain subsidies or whatever. And healthcare is not seen as an industrial sector. I'm not saying that we should support economically the sector, but I'm saying that you can compare the different sectors in their economic importance. That's all.
Thank you. There were other questions over there.
Thanks. Mark Stork, I'm also a health economist. I very much sympathize with the points that were made, but still, in some of the economic arguments we want to make, there may be a downside. Just one example from Professor Henke. I mean, one of your last slides, the three hypotheses. The last one was, I think, healthier population will reduce healthcare expenditures. That may not be the case. Yeah, it may be just the opposite, but that's not a reason, I think, for not investing in it. So we need to be a bit careful how we play some of the arguments, because we might be measured by them and we might lose some of the arguments. And another, relating to Professor Jonsson, you presented some of the studies on the relationship between health and growth, which supported our case, but there are also studies which go in the opposite direction by no less famous economists, yeah, Pammolli and Jonsson. So there's very much a debate on at the macroeconomic level of whether health is really good for growth. There isn't so much, I think, at the microeconomic level. So again, we need to be probably a bit careful how we play that, and I think probably, yeah, just a bit more nuance, perhaps. I don't know.
I mean, the first question referred me to the curve that you have shown, where you have the age on the one hand and the expenditure on the other hand, and then you have this curve that goes like this, and now we are talking about the compression of morbidity, and some people say we will have this compression of morbidity, others says we do not have. We have a steepening of the curve. I think the older we are, the less costly is the surviving, and this means only in relation to very high ages, 90, 95. But the thing, on the way to this age, it might be more costly than before, but I don't have the figures, so we need more research on the compression of morbidity. But in case we would have it, it would be very nice economically, of course.
Well, I think it's absolutely correct that you will have some econometric studies also on the determinant of growth, with probably say no effect of health, but in those models sometimes you see no effect of education. You may say no effect of a lot of other variables as well. I think that what we of course need to do, as in any research area, we have to understand how health is affecting growth, and I also think it's very important that we are notifying that economic benefit is one part. It's not the only one. It's not necessary that prevention pays for itself by reduced healthcare expenditure, but if there are reduced other healthcare expenditure, if there are productivity effects, where there are different effects, I think it's very important to also take those into account. That's of course why I also said that we should always try to look in a social perspective, both for cost and benefits of different things, because we would like to count everything, but we will only like to count it once, to not have double counting.
I would even add a few things to the health dividend. I have the impression that you think the health dividend can only be positive. I mean, there are dividends possible that are negative because the health is not improved. Say we have a huge reduction in production, or we have a severe economic crisis and everything goes down and you cannot produce anymore because everybody is ill, then of course the health dividend might be negative. I mean, this is an exception, but these are both sides of the picture, and I've only shown mostly the side of the picture.
Question over there.
Hi, my name is Richard Torbett, Chief Economist at FPIA, another economist who appreciated the session, I'm afraid. I'd like to raise an additional question which I don't think has been covered so far. We've heard the debate about health and growth, and my sense on the evidence is it depends what countries you include, and there's obviously a debate about the shape of the curve. What interests me, though, is the title of this conference, which is Sustainable Healthcare Systems, and I don't think we've really addressed the question yet about what level of healthcare expenditure is sustainable versus not. And my observation is that the current approach to looking at sustainability by the macroeconomics economists within the Commission is rather arbitrary. They use a threshold of debt to GDP of 60%, which comes from the Stability and Growth Pact, which was never intended to be a benchmark for sustainability. And for the history, the UK had a debt to GDP level over 300 years of well over 100%. So 60% of GDP is a rather arbitrary benchmark. And I think it's incumbent on the economists in the room that we improve our thinking about what is sustainable expenditure versus not. We don't have an answer to that yet. And I think, Fabio, we've discussed this in the past, and I think the point about interchangeability, or sorry, not intergenerational equity is the key one. But we need to better quantification to understand what size of intergenerational equity are we talking about here, and what level of is acceptable.
Now, on the one side, an easy answer would be we don't know, because which is an easy one, but it's also the truth, I would say, because of the fact that it will really depend on the evolution of several variables, on the evolution of our preferences. So this is why, also discussing with Bengt before the session, let's think about it in a rather different perspective. We are basically talking about consumption for goods and services at different ages, and our preferences at different ages. So this is why, for example, I'm totally sympathetic with your point. We have a tension between sustainability defined in the way in which it is defined and the future evolution of our preferences and consumption capabilities when we will be old, if the funding is designed in the way in which it is. Because if it is designed in the way in which it is designed, this tension will be there, and will be there in even stronger forms. So this is why we need individuals to anticipate an uncertain future, uncertain in terms of the entitlements, in terms of the preferences, in terms of their status, by having income which is prepared during the working age to complement, which is only a partial answer to what you are saying, but at least it will help us to decouple our representation of sustainability from a public finance point of view, which then induces other consequences, because then if you have an increasing expenditure in one chapter, you need to raise taxation or you need to increase debt, and there are costs on both sides. And so this is why dynamically I think it's important to anticipate these unknown future contingencies and to adjust early on. This is why I like the first answer I gave you, that is to say we simply don't know. And we need to adjust for that.
Well, as I think we very often discuss sustainability without exactly defining what we mean. It may have to do with mobilization of resources. If we get into problems with that, at a certain point there is no sustainability. So that, but we are not there, and I guess we are far from that. I think sustainability also has to do with the way we're organizing and financing, and for example, as with the discussion we have about funding system, etc. That is important for sustainability. But I put down my marks, I think, on the third one. Is I think that sustainability, as I see it today, the main issue is about the transfer of these resources into outcomes, into improved health, into quality of care, etc. And I think I've heard that particularly in this, that healthcare systems is neither efficient nor fair in this. And this is a major problem. And if I'm, of course, coming from a country where we haven't had so much discussion, mobilization of resources, and not so much discussions actually about how we are organizing and financing it, because that's quite well settled. But what everybody is talking about is of course the way the healthcare could reinvent to really produce outcomes. And that's, I guess, also in the point of innovation. We are talking about new cancer drugs who are very expensive. Well, what are they producing in terms of value and outcome? And to demonstrate this in a way that we have data. This is, as I see, is a major issue in sustainability from where I can to today.
Perhaps I may add two simple answers to what you were talking. I think we are discussing now the comparison between pay-as-you-go versus funded systems. And when I would make it very easy, I would say pay-as-you-go is something we have had since Bismarck, through 2 world wars, through all the inflations, through all the economic recessions. But I can give another answer. In case we go into the intergenerational equity, we need funded systems. And they can only assure that this is then equity over lifespan, because you are paying as one member of a cohort, and then you are getting back what you have paid in by funding the system. But then we must all discuss the advantages and the disadvantages of the system that we have for the private insurances. And there are other things that are not so good. But theoretically, you could have this in a funded system for insurances, and then you could decide whether you go the pay-as-you-go way or the funded way. And this is your decision then.
We'll take was the last question over the, no, it was the lady, yeah.
Yes, hello, good afternoon. My name is Isabel Klinert. I represent the European Generic Medicines Association in Brussels. So we represent the generic and biosimilar medicines industry throughout in Europe. And I find it very interesting that you talk about economic growth and that health is part of economic growth. But what about savings? What about how can we achieve measures that do actually contribute to economic growth through savings? I just want to say that our the generic medicines and biosimilars provide 35 billion euro savings each year to patients and healthcare systems, and I haven't heard once generic or biosimilar either in the strategy, nor in the vision, nor in the discussion about how we can contribute to economic growth. So I was wondering whether you could take up some of these reflections. Thanks.
Very good question. We are completing a study on that. You know, Bengt mentioned at the beginning of his presentation, I don't remember if it was Bengt or you, it was you, the competition. And in fact, what we see from the last 15 years across member states in Europe is that with all the imperfections that are possible in life, but competition in the off-patent segment of the market is an achievement already for most member states. To be honest, it's important to have competition on the market. There is already an issue of savings for the payer, which is the critical dimension here. Then there are issues on industrial policy and on competition policy, and it is important to monitor this segment. But it is certainly a segment that different member states and agencies have approached since 10 years. And I think, all things considered, is one success story for competition in Europe until now. So I have a rather, you know, it's an important component, and it's an important example of being able to raise savings in areas in which products and service age, like individuals, and so to promote competition. At the same time, evidences are important in order to see what can be improved. But I can tell you that 15 years ago, the US market seemed completely different from most European markets. Now, if you compare volumes, prices, and savings across different payers, you see that Europe was able to introduce competition in the off-patent segment of the market. Unfortunately, we need to conclude it, and then we can do it individually. I thank you, and we have about 10 minutes, no more, for the coffee break. Then we will have the session. Only one coffee.